Hello, thank you, and welcome to another Sharing Hope Community Conversations. My name is Nyemade Boiwu, and I am NAMI Delaware's Diversity and Equity Fellow. Today, we have with us two wonderful guests because it is May Mental Health Awareness Month. And in honor of that, we are going to be discussing some common mental health disorders. And so we have with us Dr. Monique Leslie and Mr. Gary Jones to tell us more about some common mental disorders and mental illnesses. But to start off, I'm going to have the guests introduce themselves and tell you all a little bit more about them. Dr. Monique, would you like to start?
Hello. Thank you so much for having me. It's so nice to meet you. Everyone, I'm Dr. Monique Leslie. I'm a clinical psychologist. I'm licensed here in Delaware. I specialize pretty much in clinical assessment, diagnosis, and psychological testing. So kind of the wide range of psychological disorders that we'll probably be talking about today, I'm quite familiar with in the work that I do. In addition to doing psychological testing, I also conduct psychotherapy, both individual and group, as well as couples. And I also teach psychology to community college students. So a lot of these topics are things that I talk about every day in terms of what I do for work, as well as my teaching. So I'm really, really grateful to be here. Thank you so much for having me.
Absolutely. Thank you again for joining.
Yeah.
And Mr. Jones, Gary Jones.
Yes, good evening. I want to begin by saying thanks for inviting me, and it's a pleasure to be here. My name is Gary Jones, and I am a licensed clinical social worker in the state of Pennsylvania and Delaware. I have my private practice, Surviving the Day LLC, and we provide individual therapy, family therapy, group therapy, primarily focused on anxiety, depression, trauma-related issues, and issues specific towards men. I'm also an adjunct professor. I do clinical supervision as well.
Awesome. Well, thank you again so much for joining us, both of you, and everybody else who's joining as well. So as I mentioned, this month is Mental Health Awareness Month. So we really want to take the time to introduce and talk about different mental illnesses and mental disorders, because, thankfully we live in a time where they are being discussed a little bit more, and where people are at least kind of acknowledging that mental disorders and mental illness is something that many people deal with. But I think it's still a subject where people don't have a lot of knowledge on. And so to start off, I wanted to talk about one of the most common ones, especially one that I think a lot of us deal with right now. And just so you know, we'll be talking about mood disorders, anxiety disorders, and psychotic disorders. Actually, let's start off by talking about what the differences are between the three. And Dr. Leslie, do you mind telling us the difference between mood disorder, anxiety disorders, and psychotic disorders?
Sure. Yeah, I can talk about the difference between the three. So mood disorders, there's a wide range of different types of disorders that encompass mood disorders, including things like depression, bipolar disorder, postpartum. So there's a wide range of different disorders that are characterized specifically by interruptions to one's mood. And so this might be things like feeling sad, feeling irritable, feeling agitated. Those are kind of examples of ways that mood is impacted through mood disorders, which is a lot different than things like anxiety disorders, which is a little bit.
And I'm sorry if everyone could just mute there.
Which mood disorders are different than things like anxiety disorders, which are specifically characterized by their arousal. So there's a lot of physiological or physical symptoms associated with things like anxiety. So this might be things like autonomic arousal, feeling anxious, feeling nervous, things like sweaty hands, heart palpitations. This may also include things like panic attacks or phobias, even disorders related to trauma are also kind of related to anxiety as well. So that's a little bit different. There can be mood components to some anxiety, but not always. Both mood and anxiety disorders are very different from psychotic disorders that you had mentioned, which is an entirely different category in itself. Psychotic disorders are classified based on kind of more either perceptual disturbances or thought disorders, as we would say. So individuals that experience things like visual or auditory hallucinations, or have kind of delusions or thoughts, kind of false beliefs are kind of what delusions are, kind of fall into the category of more of a psychotic disorder. You can sometimes have mood and psychotic disorders that exist together. The same thing with anxiety. We call those co-occurring disorders when we see more than one classification. But that's pretty much an overview of kind of the separation and the difference between the three major categories of those disorders.
Great, thank you so much. And yes, I know there's quite a difference between, I think anxiety disorders and mood disorders are definitely two of the most popular ones that people are kind of aware of. I definitely wanted to include psychotic disorders in there because schizophrenia is under that as well, correct? Under psychotic. And that one, especially with this being sharing hope, particularly for the Black community, that is one that impacts us. And it's actually a disorder that Black men are often overly diagnosed with, but we will get to that. I wanted to talk first about anxiety because unfortunately, with everything going on in the world right now, I think it's something that a lot of us are feeling and are dealing with. Gary, what is stress is part of every day, and being a little anxious is part of every day. What's really the difference between someone having regular anxiety and when they have symptoms or things to look out for that would let them know that it's more than that?
One of the things you'd want to look for would be length, time, duration that a person is anxious or depressed. So what we're looking at, what we have to look at is we have to see that everybody's anxious. Everyone has anxiety. Everyone in this room has anxiety. Everyone in this room gets depressed. The difference is when it gets to a level where we're talking about distress, mental distress, emotional distress. When it gets to a place where it's not just being anxious or having anxiety over a test that you have to take, or being a little anxious about this being the first day of work. We're talking about anxiety that to some extent emotionally and to some extent even physically can sort of disable you. It gets you to a point where, or it can take you to a point where you really can't function. So for example, a person can have a panic attack and they might feel like they're having a heart attack. Those can be some of the symptoms because the anxiety, the stress has gotten to a level that they, at this moment, seem that they feel like they can't control it. They feel like they can't decrease it. And so, but the base of it may just be anxiety. Now that base, the anxiety could come from a lot of different places. It can come from, once again, situations that they're dealing with, situations that they've dealt with. The thing that I would say we want to pay close attention to would be, once again, the nature of where that anxiety comes from. Some people have experienced things in the past that mirror what they think that they are experiencing right here in the present. And so even though it might not necessarily be the same exact thing, it feels that way. So the stress level goes up, the pressure goes up, the anxiety, all of these type of things, the nervousness, everything increases to a point where a person feels that they don't know how to handle this. So would be, I would say, the major difference between a person that has regular anxiety and that just might be regularly anxious about something and someone that's dealing with this long term, someone that's dealing with this on a regular, consistent basis.
And you mentioned panic attacks. Now, I think most people use that in general terms of when they are feeling overly stressed in that moment or their bodies are physically reacting. But there's actually a difference between a panic attack and an anxiety attack, correct?
There is. I mean, there's a difference. They can mirror one another, to be honestly. I think that most times people don't get it, but a panic attack basically is something that's going to impact you physically, or that appears to impact you physically. It is something that, once again, is, your heart is racing. You might be sweaty. You might be feeling tingly. You might be feeling dizzy. So those are things that from what I see is where the panic attack differs. Anxiety attack could be something you can have really extreme anxiety, but not necessarily something that's physically attacking you, if that makes any sense. So yeah, there's definitely a difference. I think part of the problem is that a lot of times people don't know the differences, and all we know is that we're having some form of distress. And we're responding to whatever it is that we're feeling at that moment. But definitely there are differences. There's similarities, but there are differences, definitely.
Right, perfect. And Dr. Leslie, it seems like oftentimes panic disorders or anxiety disorders are coupled with mood disorders. Is that just by the nature of them? And then can you also just give us some more information on mood disorders and like the basics of them?
Sure. Yeah, so as I mentioned a little bit earlier, we often see what we call co-occurring disorders, where we see multiple diagnoses. So we might have some disorder characterized in a mood category, as well as anxiety or some other disorder that we're looking at. We do see depression and anxiety sometimes coupled together. It's not always like a criteria for one or the other, but sometimes we do. What I ask people when I'm doing my clinical assessment is I ask them what's kind of predominant. Is it the depression is predominant, or is it the anxiety that's predominant for some people? And often they can tell you. They might say, I'm more depressed, and then I oftentimes will feel anxious, or they may say, I'm anxious all the time, and then I have moments of things like depression or dysregulation. So I often allow the patient to guide kind of the assessment when we're looking at kind of whether or not we're seeing more of a co-occurring disorder. There are also other kinds of disorders that encompass both anxiety and mood. So something like a trauma-related disorder, which picks up on both mood-related symptoms as well as anxiety-related symptoms. And so as I'm doing an analysis of someone, that's something that I take into consideration. Is it depression, anxiety, or both? Or is it something else completely?
Sorry, I could just interrupt. Sorry, just for a moment. Could everybody please make sure their phones are muted?
$20 in it. Brayden, you just got my Valentine's card.
Okay.
But still, but Valentine's Day was in February.
Adrella, could you please mute your phone?
Wait a minute, hold a minute. Do what, my phone?
Could you please mute your phone? Thank you so much. Okay, sorry, Dr. Leslie, continue.
Sure. Yeah, sure. So I was saying, as far as like the co-occurring disorders and how to distinguish between whether we're seeing either the depression or anxiety or both, or even an entirely different disorder altogether. The other part of your question was asking a little bit more in context about mood disorders in general. And so that's something that we see quite often. Is mood disorders is probably one of the leading disorders when we look at common, right, is some type of mood disorder in any particular. The thing about mood disorders is that they can exist, like I said, in the context of other disorders. So we can see mood-related issues in someone that has psychosis. We can see mood-related issues in someone that has trauma or eating disorder. And so it's something that we see quite a bit. But when we're looking at kind of its own diagnosis as a mood disorder in and of itself, that's something that we might see in absence of some of the other issues that we'll see when we see kind of that co-occurring. Some of the most common mood-related disorders are going to be your major depression, which is one that people are primarily familiar with, kind of a general depression. Bipolar disorder in some contexts is another major mood disorder that we see often. Postpartum disorder, peripartum disorder is something very common. The DSM-5 has also included things like premenstrual dysphoric disorder, which is a type of depressive disorder as well that we see in females around kind of a cycle ovulation. And so we see a wide range of different types of mood-related issues, again, whether they exist independent of themselves or in combination with other disorders. Interestingly enough, when we see kind of a mood disorder like depression coupled with something like psychosis, as we were talking about, we call it schizoaffective disorder. So it has its own name, which is schizophrenia with depression or schizophrenia with bipolar disorder. So that we're not giving people, 3 or 4 disorders. We kind of have one that encompasses, okay, there's psychosis present, and we also see mood dysregulation. And so it can take a look like a lot of different types of things, but depending on kind of what the patient is presenting with, what they're reporting, what areas they're having difficulty in is kind of where we kind of can classify what might best classify where their mood issues are related.
That makes a lot of sense. Now I have a question because, I think people know the general terms of bipolar disorders as, really manic periods and like really highs and lows. But as someone who also like lives with depression, I know that sometimes when you are going through that, I call it like the dark phase, my dark cloud phase, when you come out of it, you feel so elated that you're like, oh, and I personally have asked my therapist, like, how do I know I don't have bipolar? Because I'm really happy, like this feels so opposite of it. So like, how does someone know, like, or what are the extremes of bipolar versus just general moving from a depressive state to a happy state?
Yeah, that's a really great question. Bipolar disorder, the term bipolar is thrown around so often kind of in lay terms where it's kind of misunderstood quite a bit. It's actually pretty difficult to diagnose someone with bipolar disorder because of exactly what you just said, right? People that deal with major depression, when they're out of the depression, they feel great, right? They feel opposite of that. A manic episode in particular, which is the hallmark classification of bipolar 1 in particular disorder, is very different than kind of just feeling better. When we look at things like functional impairment, right? When you're feeling better from depression, you might just kind of go about your day-to-day life, right? You may not be doing things like spending thousands of dollars at the store, at the shopping, or staying up all night, or getting undressed and doing kind of really impulsive types of things. If that's kind of your baseline and that's kind of how you are typically, then we might want to ask ourselves, is this someone that is dealing with something like a manic episode, which would then classify their depression as more of a bipolar than just a general depression. And so there's a stark difference, right, between feeling good kind of because you're not depressed and feeling manic because your chemicals are now kind of tipped in the other scale, and now you're kind of in a space where you're very impulsive, you're not able to sleep, and so there is a stark difference. So I'm really glad you talked about that, and it's not the same as kind of just feeling better from your depressive episode. It in and of itself, mania is a disorder and can classify someone as going into the hospital. You can have psychosis during a manic episode. And so unless that's kind of your norm when you're not depressed, then we don't really usually tag on bipolar disorder to someone's depression.
Okay, that's great to know. Thank you. And when we talk about, phrases that are commonly thrown around, OCD is definitely one of them. And Gary, the OCD counts as an anxiety disorder, correct?
Yes.
Okay. Can you give us a little bit more information? Because people instantly think like, oh, I like, my paper straight, I have OCD, or I like things clean, I have OCD. And we know that it's more than that. So can you give us a little more information about it?
So once again, I think we have to be able to make a distinction between what's normal in terms of like a person that normally likes to keep a clean place, or normally likes to be organized, or and between that and a person or an individual who is, this is like, so it becomes to a level of being obsessive, which is part of the term OCD. In other words, we're looking at an individual who it's not just enough to turn the light off, to turn the light switch off. this might be one of those things where you might go back and forth and you turn that light switch off maybe several times before you decide not to do it. You know, we're talking, I mean, I think one of the examples, I know that most people, when they associate OCD, they might associate it with being people that wash their hands. We all like clean hands, you know, but there's a difference between clean hands and constantly we're washing our hands. So we're looking at a behavior, an action that becomes a part of us to the point where we really can't stop, or it appears that we can't stop. And once again, that's where the obsessiveness comes in, and because it becomes something that we are doing almost to the point where it seems like we just can't stop.
And so it becomes really disruptive for people's lives.
Yeah, it does. I mean, it once again, it's not, I mean, I like what Dr. Leslie said earlier about baseline. When we look at, if we go back and we look at in general about, when we look at a baseline, we're looking at what a person's usual behaviors would be. What are their normal behaviors? You know, what are the things that they would do? We can also compare that generally maybe across a span of what other people may do in certain circumstances. So normally we're not washing our hands 8, 9, 10 times a day. We're not. Usually with that, there could be some sort of silent distress that's inside of us that, you know, we just feel we just have to do that. But that's the difference, understanding that this goes from what we would consider to be normal, you know, whatever normal is considered to be. So yeah, I mean, basically that would be, I mean, that's kind of pretty much where we would be. I mean, that's where you want to go from. So when you know what that baseline is, then you know what you're looking for, and then you can be able to help help an individual understanding if this is too much, if this is too excessive. Why are we doing this? You know, what's bringing this on? There could be a lot of things. Once again, especially when we're dealing with mood disorders, it could be stress. It could be internal stress. I mean, the internal stress that we deal with. It could be the external stressors that we're dealing with that we might not even realize that we're dealing with. So when we're looking at something like OCD, all of that becomes a part of it. Now, for most individuals, or for some individuals, this becomes a part of their normal routine, whether they know that they're doing it or not.
And when we talk about normal, something that's normal is socializing, which seems like, you know, from a young age, we're sort of conditioned to socialize and talk with people, but some people develop actually social anxiety. Can you tell us the difference between just regular general anxiety and social anxiety? So
once again, regular anxiety would be, the way I would categorize it would be something where, you know, I might be anxious about being here tonight. I mean, I might be anxious about the normal anxiety that goes with trying to prepare for an event like this. Social anxiety is going to keep me from doing an event like this, basically. You know, so my anxiety gets so heightened that, you know, I can't participate in an event like this, or, you know, the way or the level that I might participate in it is going to be severely restricted. You know, so I might find myself stumbling or a lot, or just being very anxious, or honestly, I just might not show up. You know, so a lot of times when we're dealing with social phobias, social anxiety, what we're dealing with is the fact that we're talking about a level of anxiety that is restrictive to the point where you just can't do it. You want to do it, but that's something, that anxiety inside of you that is so high, that nervousness that's inside you that is so high that it literally restricts. There's literally a fear to some degree that keeps you from doing the thing that you want to do. Once again, using that the term normal, a person who doesn't experience that will once again have some anxiety. We all have some anxiety. I think that's what we have to remember when we talk about these things. We all have anxiety. We all have depression. Some of us have a level of feelings that are kind of related to some of our traumas. But the question is the level of distress, and does it prohibit us from doing the things that we want to do? For example, one of the anxiety disorders is agoraphobia. I've worked as a therapist, I've worked as a case manager over the years in terms of being in the mental health field, and I've seen a couple of different examples of that. I've seen one client who was so afraid to go out that honestly, for years, he didn't venture far from it. He basically went to his front door, he'd reach out, pick up what he needed to do, and then go right back inside. Basically, his home became his prison. And that is a form of agoraphobia, where you're afraid to go out, you're afraid to do this. You don't want to go here, you don't want to go there. Another extreme of that are people who will go, but they're measuring how long they're going to be out. So you have people, I had one client who we knew that our time limit was 2 hours. Whatever we were going to do, we were going to get it done in about 2 hours. Because around about that hour and a half range, she would start to get anxious, anxiety start to pick up, and then she would need to go home. So agoraphobia can look different for different people. But once again, we're talking about a level of anxiety that prohibits a person from normally socializing, normally interacting with someone, just being afraid to even start a friendship or maintain a friendship.
Yeah, and I mean, with agoraphobia, it's something that I've been worried about with myself lately, because I have regular anxiety, but then we had quarantine, and I'll be honest, I was one of those people who enjoyed quarantine because my anxiety was so much decreased, because I wasn't, worried about like my friends and family out and what would happen. And that kind of created like a baseline peace for me, that when we started going back out, I realized I was more anxious than I was prior to quarantine. And then on top of that, with the shootings, with the things happening in other countries, it's sort of increased that level. Have either of you seen an uptake in that, with people having it actually even worse than prior to COVID and quarantine?
Dr. Leslie,
Yeah, I can speak to that as well. I know during the quarantine, there was a huge uptick in mental health referrals for people that were anxious, right? And the anxiety could have just been around getting sick and getting COVID, right? And then in and of itself. And so that was a lot of kind of referral issues kind of during the quarantine. Probably around last summer, I want to say, at least from my work, I saw a lot of people coming in for anxiety about exactly what you're saying, about reintegrating back into this now kind of post-COVID or still COVID kind of society that we're in. And after spending, 2 years, if you will, kind of locked down, what do I do now? And so the anxiety just is around like, how do I interact with people? Do I get too close? So definitely seeing a lot of people concerned about their anxiety, both related to kind of getting sick and or kind of socializing. Should I wear a mask? Should I not wear a mask? And just that anxiety existing, even if it wasn't before the pandemic. So for sure, definitely a lot of kind of new cases of anxiety I've come across.
It's very interesting. It's just sad, and also because I know that with the I was part of the NAMI conference a while ago, and there was a speaker who was also mentioning that, unfortunately, due to the pandemic, with the mood disorders, depression, there's been an uptake, and actually, unfortunately, an uptake in suicides as well, but particularly in the Black community. And where it's like before, it was, if you did the different races, we were kind of like paired the same. There's actually been a decrease for one, and ours has actually had an increase, which is always sad to hear.
I mean, no doubt. I think that COVID has changed and challenged a lot of the ways we look at things. As Dr. Leslie was saying, there are people who don't want to go out. People are afraid to go out, and it's not just COVID, but I think that has been a big piece of it. In Philadelphia, we're looking at, violence every day. Every day. And it's really, it's not only, I don't even want to say it's crazy, it's scary. So something about COVID-19, I think for some people, enabled people to feel safe because I don't have to go out. I don't have I have reasons not to go out now because there's, the numbers are high and I just don't want to be out there. I don't need to be out there. So therefore, I'm not going to go out there. But that's, so some of those things were in place beforehand. And then when you throw in all these other things, it just increases things. Suicide within the African-American community has always been a difficult subject because we within our community don't handle it very well. And we really haven't looked at it as being a serious issue. Not that we don't see suicide as being serious, but we have been able to, or we have felt like we've been able to attribute it to other things. And so therefore, I think what has happened is that we've missed a lot of the signs, a lot of the things that, that maybe we could have caught, we missed them because just culturally, we might not have been looking. Suicide, honestly, within the African-American community was not something that was considered it wasn't considered a Black thing. It just wasn't, it is. And as we see the data, the numbers are showing that our kids in a certain age range, between teenagers and especially moving into the early adulthoods, they're dying and committing successfully suicide at a higher rate. So that is a major issue and definitely an issue that I feel that we have to try to address. We have to try to address this as best as we can.
Yeah, absolutely. And I think it's a good thing that it seems on the side of psychology that we're starting to take cultural backgrounds into consideration with diagnosis and with trying to figure out how different things impact us, because some things present differently in different races. And because they're all looked at under the same microscope, it impacts how the diagnosis happens. Dr. Leslie, I know I mentioned a little bit earlier, but if you could speak more about schizophrenia and sort of what that looks like, and also why we're sometimes in error overly diagnosed with it.
Yeah, that's a good question. I'm glad you did talk about kind of the presentation of how certain disorders look in different cultures, and that's so important. I will say, unfortunately, it is not something that is taught or well known across clinicians. I'm going to tell you right now, just as a psychologist, as far as consulting, people don't think, right, to consider cultural considerations. It's so important to understand that what it looks like for me and people in my family does not look the same as from a white family or Hispanic family or Asian family. And so really understanding the cultural context of any disorder is so important. Schizophrenia is one of the disorders that is often taken out of cultural context so frequently. It's very, very unfortunate. There is a high prevalence of schizophrenia that is in the Black community that does exist. So I will say that. So it isn't that it doesn't happen, it does exist. That does go undiagnosed and untreated as well. On the flip side, there is an overemphasis on a lot of types of behaviors that are looked at in the clinical community as being like psychotic or associated with schizophrenia that are very culturally specific, right? And so, for instance, if we have a patient that is religious and they, quote the Bible or they quote their spiritual texts when they're talking about their distress and ailments, there might be a misinterpretation from the clinician on the other side that doesn't understand that Black people read the Bible, not all, but a lot of Black people read the Bible and they go to, their pastor, they go to church or they turn to the word to understand kind of what their experiences are. And they'll be labeled as things like, schizophrenia with a religious delusion or something like that. Mm-hmm. When people of color or people of another culture get agitated, right? How do they express that, right? What does that look like in our culture, right? Sometimes we talk a little bit louder. Sometimes we use our hands when we talk, right? And other people, they might see that as kind of a clinical symptom. They might pathologize what would otherwise be what Mr. Jones had talked about, normal behaviors from a cultural context. And so it is very important to understand that what schizophrenia looks like in the Black culture is not always the same as what it looks like kind of based on what some of the diagnostic criteria is made. And so I found myself when I worked in the prison in California, for many Black men in particular, kind of challenging the diagnosis of schizophrenia, right? And having them put on these significant antipsychotic drugs. And in reality, this is someone that's severely depressed, right? And there's no psychosis going on. This is just someone that is using their cultural understanding of how to cope that is now being pathologized. So I've seen it many times over. It happens more often in Black men than any other race, any other gender, across the board. California, I'm licensed in Texas as well. And unfortunately, that's the one diagnosis. When I see Black men diagnosed with schizophrenia, I go, let me reassess this real quick, just to be on the safe side. And unless I see, some stark evidence saying otherwise, or they have a significant history of psychosis, sometimes I do challenge that myself, honestly, because unfortunately, the misdiagnosis is so prevalent in the Black community. Yes.
Mm-hmm. And you mentioned, working in the prison system, it's, and I won't get on my soapbox right now about the over prison system and the over arrests of Black people, but it is definitely something that happens. And what people don't realize is that a lot of times it stems from mental health issues and mental health concerns. And they've even done studies like, in California, where not just the prison system, but also juvenile, like the younger age, rather than, whereas in some other cultures or communities, they're able to, be kids and be given the resources to get help, where they would be able to see a therapist and uncover those. Oftentimes in the Black community, they're just put in jail. And even then, even though technically prison is supposed to be a rehabilitation center, we know it's not. It's really more just about free prison labor. So they're not getting those psychiatrists and they're not getting those help that they need. So you have a lot of people with, like you said, depression and other disorders that are just being locked away because maybe they're expressing their sadness through anger. And someone mentioned in the chat that minority cultures don't really respect mental issues. And I think that that's also part of it, right? Like no one wants to say, I'm sad, so they're just angry, when really it's the way that they're presenting their sadness.
Yeah, and also to kind of speak to that point, I mean, again, if you're misdiagnosed, right, when you go to see a clinician, of course you're not going to want to go. Of course not. If I go in there and I tell them that, I've been praying 3 times a day and I still don't feel better, and they tell me I'm psychotic, I ain't going. I absolutely understand. I deal with that almost every day when people are like, are you sure? Should I trust you? And I'm like, you don't have to, but I'm gonna tell you, I'm gonna keep it straight. But yeah, lack of education, honestly, is really what that's about. Lack of cultural awareness is what that's about. Lack of being transparent with our people and letting them know what it is, rather than writing it down and then not saying anything, right? No, I'm gonna let you know. I see depression, I see trauma, I see psychosis. I'm gonna let you know so that you could take my word for it, or you can go to someone else and have them tell you or not tell you. But yeah, the mistrust is 100% understood. I get it. As a Black woman and a psychologist, I get it.
And I think that's one of the things that is not always addressed, but something that needs to be addressed. A lot of times clinicians and a lot of times non-clinicians of color don't really understand or take the time to know what it might look like in us. And I like what Dr. Leslie said earlier in terms of, certain symptoms, certain things that we see might look differently cross-culturally. Within our community, a lot of times what a lot of clinicians don't understand is what does a Black man have to experience? What does a Black woman have to experience? What does it mean to be a Black mom? What does it mean to have that fear of, your child leaving the house every day, not knowing if your child is going to come back home again? wondering what does it mean if your young Black son is going to have to worry about what he says to the police officer to make sure that he doesn't get locked up, or is that police officer just having a really bad day? So, I mean, I think those are some of the cultural concepts, I think, that a lot of clinicians don't get. Now, it's not specifically designed, it's not specifically just like aligned just with non-clinicians of color. Some of our own folk don't get it. Okay, so I don't want to make it sound as a black and white thing, but a lot of times that's what I'm saying. So people are coming to me, not because I'm a black man. I mean, that's obviously a dynamic, but because they feel as though I'm going to be able to understand, something that maybe another clinician just totally missed, totally didn't understand, totally didn't even think that they needed to really figure out. It's one thing to diagnose a kid with anger, but it's another thing to figure out where does that anger come from. What's the orientation of that anger? Why is that child angry? What has he or she seen? What have they experienced? Those are the type of things that we have to be able to help our community understand. So part of it for us is that we don't trust. We don't trust because of the historical things that have happened, but also the other part of it is that we gotta educate. I like when I'm speaking with people, and